Welcome to Diagnostic Imaging's Weekly Scan. I'm Senior Editor Whitney Palmer. Before we get to our featured interview of the week with Dr. Jennifer Marin from the University of Pittsburgh Medical Center about advanced imaging utilization with pediatric patients, here are the top stories of the week. After all the anticipatory talk about whether a portable low-field MRI would be able to produce images that were accurate and of diagnostic quality, a study was published this week in JAMA Neurology that shows it can effectively assess patients in the intensive care unit for brain injury, just as well as conventional imaging methods. According to a team from Yale New Haven Hospital, the 64 microtesla MRI that can plug into a standard electrical outlet in any room matched the performance of standard imaging with both patients who were infected with COVID-19 and those who were virus-free. They tested the technology between October 30th, 2019 and May 20th, 2020 with 50 patients, 20 of whom were COVID-19 positive. The remaining patients had suffered ischemic, hemorrhagic, or subarachnoid stroke, or they had traumatic brain injury or a brain tumor. All patients also underwent conventional CT or MRI as a comparison scan. Based on their analysis, the portable MRI identified neurological findings in 29 of the 30 infection-free patients, a performance that corresponded to the results of conventional imaging, except for one diffuse subarachnoid hemorrhage. In addition, the portable system pinpointed findings in 8 of the 20 COVID-19 patients, including intracranial hemorrhage, cerebral infarction, diffuse cerebral edema, and leukoencephalopathy. This performance was identical to that of conventional imaging. These results, the team said, shows the potential of portable assessment of neurological injury in other scenarios, including the emergency department, mobile stroke units, and resource-limited environments. And when it comes to COVID-19, cardiac MRI can have an important role to play with competitive athletes who have recovered from the virus. In a study published in JAMA Cardiology, a team of investigators from The Ohio State University shared their results. The team conducted cardiac MRI on 26 competitive athletes with an average age of 19.5 years, who either ran track or played football, soccer, lacrosse, or basketball. Some athletes, 12 individuals, reported mild infection, including a sore throat, shortness of breath, fatigue, or fever, while the remaining 14 individuals were asymptomatic. Based on the scans, the team determined 4 athletes had evidence of myocarditis based on the presence of myocardial edema and myocardial injury. Other athletes also experienced myocardial inflammation. Based on these results, the team said, cardiac MRI can potentially identify a high-risk cohort for adverse outcomes. It may also be able to effectively risk stratify which patients can safely resume competitive play, as the scan has a high negative predictive value for ruling out myocarditis. There was also news this week in the treatment of prostate cancer. In a study published in the Journal of Urology, researchers from the University of Southern California in Los Angeles laid out the results of their work with high-intensity focused ultrasound, or HIFU, and its potential to help men avoid more invasive treatment options, such as surgery or radiation therapy. By testing HIFU between December 2015 and December 2019 with 100 men who had localized prostate cancer, they found the strategy was effective for most men. The team defined failure as a prostate cancer recurrence, radical treatment, systemic therapy, metastasis, or death specifically related to prostate cancer. Based on their evaluations at initial follow-up, they discovered 73% of men avoided treatment failure and 76% had no evidence of clinically significant prostate cancer. In addition, 100% retained continence. After 2 years, 91% of men had avoided radical treatment and only 13% had experienced minor complications. Overall, the team said, they believe their data represents actual clinical practice in the United States. In addition, this week, the American College of Cardiology published updated guidelines calling for greater use of coronary CT angiography in the Journal of the American College of Cardiology. This guidance reflects evidence that shows that for patients who have no known coronary artery disease, providers should look to pinpoint coronary atherosclerosis instead of myocardial perfusion abnormality when looking to identify the disease. To move the industry toward coronary CTA first strategy, the ACC made 6 recommendations, including using coronary CTA as a first-line test for patients with stable chest pain, exploring bundled payment options for cardiac testing, identifying ways to increase the number of coronary CTA providers, establishing a coronary CTA registry for evaluating chest pain, engaging commercial payers to potentially eliminate pre-approvals for the test, and improving provider education about when to consider coronary CTA. And finally this week, Diagnostic Imaging spoke with Dr. Jennifer Marin, Assistant Professor of Pediatrics and Emergency Medicine at the University of Pittsburgh Medical Center, about her recent study published in JAMA Pediatrics that examined the changes in the utilization rate of advanced imaging with the pediatric population. She talked with us about some of the surprising results of her findings with CT, ultrasound, and MRI, as well as how these results can potentially inform clinical decision-making with children in the emergency department. Here's what she had to say. Thank you again so much for taking the time. I do appreciate it. To kind of get started, when we think about this study and what your population was, what was the motivation for looking at the advanced imaging utilization in kids? Because we've had Image Wisely and Image Gently and Choose Wisely for quite a while now. So why look at this now?
Right, good question. So, anecdotally, my collaborators and I were noticing that ultrasound and MRI were really being used a lot more in recent years for conditions where advanced imaging was needed. And we decided to study it a little more formally using data from the Pediatric Hospital Information System, which is an administrative database of U.S. children's hospitals. So we looked exclusively in pediatric emergency departments and really wanted to evaluate whether what we thought we were seeing was actually happened. And to your point, Whitney, about choosing wisely and Image Gently, those campaigns were very much targeted toward reducing unnecessary imaging, as well as reducing CT use whenever feasible. And so it was in the context of that also that we wanted to evaluate what was going on with CT patterns, because again, we were noticing that we really weren't relying on it as much as we had in the past.
Gotcha. Okay, well then walk me through exactly what you did. Like you said, you looked at emergency department usage, but kind of break down for us what it is that you did, and then ultimately what you found when it came to changes in utilization.
So what we did was we evaluated advanced imaging use across all emergency department visits to pediatric emergency departments. And the point was that we wanted to look at trends in 3 specific areas. So ultrasound, MRI, and CT, as well as overall advanced imaging patterns. And the primary goal really was to look at the change in the last decade. So what's happened overall, as well as in each of those specific modalities. And then one of our secondary objectives was to look at variability across hospitals. And were these changes that we were seeing consistent across the hospitals that we evaluated? And so what we found was that, in fact, our hypothesis was correct, that ultrasound and MRI were being used more relative to a decade ago. And CT, in fact, had declined. But I think what was very startling and surprising to us was the extent and the degree to which ultrasound specifically had increased. We really noticed a much larger increase in ultrasound than the decrease in CT. And overall imaging, advanced imaging, has really increased. And that suggests that the possibility of some overuse and some unnecessary imaging taking place. The other interesting finding was that, in fact, CT overall did decrease. So relative to 2009, we're using CT much less. But what we noticed when we looked across each year was the first 5 years of the study, in fact, there was a pretty steep decline in CT. But since 2014, we really haven't made many strides in that area, and things have really plateaued. So it's almost as if we've reached some sort of a threshold.
Interesting. Given that threshold is there anything that we could potentially point to as reasons why we've kind of seen that stagnation occur?
Right, it's a good question. So I think the question is, why is it that we can't decrease our CT anymore? One hypothesis could be that this is the sweet spot where the CT that's being done is appropriate and there's really not a way to decrease any further. But there's been a couple of studies actually that have looked at Canadian data compared to US data. And we know, in fact, that the rates there are much lower using CT. So I think that we do have room to go in terms of decreasing our use even further. And the reasons for why we use CT, I mean, it's a quick test, it's a fast test, it's available. Most of us have a CT scanner right around the corner as part of the emergency department. And it can be challenging. A lot of hospitals don't necessarily have access to MRI, let's say, that's readily available. So I think it's probably multifactorial, but we certainly have some room to go.
You mentioned the decrease with CT, but also the uptick in the use of ultrasound and MRI. Is there a direct, I guess, correlation there as far as, you see this drop in CT and this increase in ultrasound, or, does this indicate, like you were saying earlier, perhaps some overutilization of these non-radiation forms of advanced imaging?
Yeah, I think it does, Whitney. The issue is it's hard to say that conclusively because that wasn't the purpose of our study. So we really didn't look, we weren't able to dig deep into individual patient outcomes. So that's really the question, right? If we are having better patient outcomes as a result of all the imaging that we're doing, then it's potentially necessary. However, I think, there's been other work that's shown in individual disease or individual conditions that more imaging doesn't translate into improved outcomes. So I think that there very likely is a portion of the increase that we can attribute as being, we can say is overuse and is likely unnecessary.
All right. So then, given all of this as a backdrop, then when we take a step back and again we look at the campaigns that have existed for the past decade or so, and then your findings in this study, what's the overall upshot? Is this good news or bad news, and what does it basically tell us about the current use of advanced imaging with kids?
Right. It's a good question. I think it's probably both. Right. I think there's positives and negatives to our findings, right? So the positives are certainly that we have dramatically decreased our use of CT, and CT is an exceptional test. It's wonderful. I think it's important that we do continue to use it when it's indicated. But when there are non-radiating alternatives like ultrasound and MRI, it's important that we use those modalities instead. And it seems like we're doing that to some extent. I think that the potential bad news is with the increased availability of a lot of these studies, it becomes easier to order them. And we have the pressures of getting kids in and out very quickly. Our volumes have all increased over the last decade. We have parents and families that are very savvy, that get on the internet, request certain tests, pediatricians who are referring patients in for certain tests. So I think that there's a lot of reasons why we're imaging more. And, the fact that ultrasound in particular is a non-radiating test, you don't have to sedate the child. It's fairly easy to get, relatively inexpensive compared to some of the cross-sectional imaging studies. It just becomes sometimes easier to order the test and just get it done.
Fair enough. So then from that perspective, because it is just easier in some instances, how should radiologists use this information in kind of guiding, emergency physicians or even talking with parents when it comes to whether or not their child might need a study?
Mm-hmm. Yeah, I mean, I think that radiologists probably have been more attuned to these trends than we have. They're the ones who are really seeing the volume of orders that are coming through. One of the radiologists where I work actually has mentioned to me on numerous occasions about the volume of ultrasounds for abdominal pain. So I think that they really know that this is existing, and they're in a difficult position because it's challenging for them to question the study. I think that in general, we underutilize our radiologists and the ability to have a conversation with them and to talk to them about imaging strategies. So I think that's one take-home point. But more than anything else, I think the onus is really on us as the ordering physicians. And our data, I believe, provide an opportunity for emergency departments to examine their imaging patterns locally and develop solutions and implement solutions to try to curb any unnecessary use.
Right. Circling back around really quickly to one particular part of CT, just to see if there's any kind of other information we can provide, but particularly with head CT, what are the changes that you saw there, and what are those potential implications when it comes to usage?
Right. So head CT really is the most common CT that we use in pediatrics, and head trauma is the most common indication. And there's been a lot of work over the last decade with clinical decision rules and choosing wisely that have promoted the safe observation of children with head injury to avoid CT. And I think that we have done a great job of listening to that data and implementing those recommendations. But again, when we looked specifically at head injury, we saw that same pattern where the first half of the decade, we had a nice decrease. We've really plateaued since 2014 and haven't made a lot of strides in continuing to reduce our usage.
To kind of wrap things up, from the overall perspective, thinking about, what you've been saying about the stagnation from 2014 and kind of getting to a point where we haven't been able to drive CT usage down any further, and we're seeing this kind of, happen with advanced imaging. Overall, in what ways can providers, be it pediatricians or emergency physicians, use the findings from your study to inform their clinical decision making? How can this, I guess, be used to improve the patient outcome and potentially avoid imaging when it's not, truly necessary?
Yeah, so I think that there's ways that we can just examine our own individual practices at the patient level, just stopping and saying, is this an indicated study? Are there other things that I can do to try to avoid an unnecessary test? Because there's harms with unnecessary imaging. It's not as simple as, well, there's no radiation, so and it's relatively inexpensive, so there's no harm. But there are harms with overuse, right? So there's incidental findings, there's the downstream effects of those, there's the cost of these studies, there's the time associated with the study. So, I think it's important for clinicians to consider the harms as well, and to educate patients too. So I think that that's a really important point as well. I think that these clinical decision rules, implementing them into the workflow with point of care clinical decision support, and standardizing really the approach to imaging. There are, for example, with head trauma we talked about, there are very robust clinical decision rules that help to guide us and to determine who can safely not be imaged and who can just be observed. And with abdominal pain, interestingly, which was another area where there was quite a bit of imaging in our study, there are a lot of scoring systems that you can use that rely on the clinical exam and, in some cases, laboratory testing prior to imaging to then risk stratify the patient and decide, this patient really has such a low risk of appendicitis, they can be discharged, they don't need any imaging. So I think that there are things that we can do, but it does take the physicians to have an active role in wanting to reduce any unnecessary imaging. And it's very challenging. It's very challenging in today's world.
Oh, absolutely it is, because everybody wants to know exactly what's going on at any given moment.
Exactly.
Well, I appreciate this. Are there any more details or any other implications of the study that we didn't touch on that you think would be important to include to help people understand the importance of what you looked at and what you found and what it could mean, as we continue to go forward and hopefully continue to drive down advanced imaging use for children?
Yes, so I think that the fact that imaging has changed so much, specifically with CT decreasing and non-radiating modalities increasing, it's a testimony to our ability to change our behavior and to change our strategies. And so I think now we just need to tweak things a little bit and think about ways to safely avoid any imaging in cases where it's appropriate.
All right. Well, Dr. Marin, I really appreciate you taking the time today. Thank you so much.
It's my pleasure. Thanks so much for having me, Whitney.